and women in low socioeconomic groups. PIH results from systemic vasospasm, arteriolar vasoconstriction, and vascular damage. Your interventions should include encouraging the pregnant woman to lie on her left side to reduce blood pressure and increase uterine and renal blood flow. Non-stress tests are routinely done to assess fetal well-being. If the woman is hospitalized, you'll monitor vital signs, edema, deep tendon reflexes, daily weights, urine output, and fetal well-being. Implementing a seizure precaution, meaning put the side rails up and padded and low stimulus environment, plus having emergency medications and equipment readily available are essential for assuring client safety. Be aware that signs and symptoms of preeclampsia range from mild to severe and will affect the fetus to varying degrees. With mild preeclampsia, blood pressure 140/90 or above, or it increases 30 millimeters of mercury systolic and 15 millimeters of mercury diastolic. Edema is 1+ pitting after 12 hours of bed rest. Proteinuria is 1+ or 2+ or even higher. And the face and hands and feet have significant swelling that does not go away after 12 hours of bed rest. Next, the symptoms of severe preeclampsia. They are a blood pressure of 160/110 or higher and extensive generalized edema, proteinuria 3+ or 4+ or higher, and headache, visual disturbances, and abdominal pain. If your client has the classic signs of headache, blurred vision, epigastric pain, decreased urine output, and nausea and vomiting, then you know the disease is worsening. With further increases in blood pressure, PIH becomes a seizure state or eclampsia. At this extreme state, the pregnant woman is at risk for fatal pulmonary edema, organ failure, cardiac failure, or cerebral hemorrhage. If you receive a call from a pregnant client who has these symptoms, it is important to keep her calm, but to expedite help. You might say something like,
"All right, I don't want you to have to deal with driving while you're not feeling well. I'm going to call 911. I want you to unlock your front door and go lay down on your left side and rest and wait for the paramedics to come."
First-line drug therapy for PIH is magnesium sulfate. You must monitor a client on magnesium sulfate for the classic signs of toxicity: a decreased respiratory rate, less than 8 to 10, an absence of reflexes, and decreased urinary output, that is less than 30 milliliters per hour. Should magnesium sulfate toxicity develop, be prepared to administer calcium gluconate to reverse the complications of respiratory depression. A variation of severe preeclampsia, called the HELLP syndrome, is an acronym for the features of its presentation, which are hemolysis of red blood cells, elevated liver enzymes, and low platelet count. Complications include disseminated intravascular coagulopathy, or DIC, acute renal failure, and pulmonary edema. Maternal complications associated with PIH are stroke, hemorrhage, cardiovascular problems, and DIC. Now, fetal complications of PIH are intrauterine growth retardation and fetal distress caused by hypoxia. Keep in mind that the only cure for PIH is the delivery of the fetus. So should the situation become critical, anticipate preparing the client for an emergency cesarean section delivery. Another complication of pregnancy is gestational diabetes, or the onset of carbohydrate intolerance of variable severity diagnosed during pregnancy. When the pancreas cannot produce enough insulin to move sufficient glucose into the cells for energy production, gestational diabetes results. Gestational diabetes is usually diagnosed during the second trimester of pregnancy with a glucose challenge test, although you can see the first signs of glycosuria on a routine urinalysis much earlier. The signs and symptoms of gestational diabetes disappear during the first few weeks after delivery. Factors associated with gestational diabetes are previous delivery of a large infant, family history of diabetes, glycosuria on 2 successive occasions, obesity, previous spontaneous abortion or stillbirth, multiparity, polyhydramnios, previous delivery of an infant with congenital anomalies, and hypertension. Signs and symptoms of gestational diabetes in the pregnant woman are hyperglycemia on a challenge test with results greater than 140 milligrams per deciliter, ketoacidosis, polydipsia, polyphagia, and polyuria, glycosuria, and an abnormal pattern of weight gain. Managing gestational diabetes focuses on maintaining a fasting blood glucose below 105 milligrams per deciliter. To do this, aim your nursing interventions towards diet, exercise, and glucose monitoring, and be sure to evaluate the fetal status. Caloric intake should be limited to 2,000 to 2,400 calories a day. Teach the client to recognize signs and symptoms of hypoglycemia and ketoacidosis. Show her how to monitor her blood glucose and urine for ketones at home. Because of the altered glucose levels in the vaginal environment, pregnant women who have gestational diabetes are more susceptible to vaginal yeast infections, candidiasis. Be sure to teach appropriate self-care and how to recognize the signs and symptoms of yeast infection so treatment may be obtained. Fetal surveillance is another area of concern with gestational diabetes, especially during the 3rd trimester. Tests that evaluate fetal status are echocardiography, ultrasound, and non-stress testing. Fetal growth patterns, amniotic fluid index, fetal movements, fetal anomalies, and placental anomalies all require monitoring during a pregnancy complicated by gestational diabetes. Teach your pregnant client to monitor fetal movements on a regular basis at home. Although there is not a uniform rule for the amount of episodes of fetal activity considered to be normal, however, the nurse would inform the woman that fewer than 3 fetal movements in an hour warrants further examination, such as NST. Recommend that she count fetal movements daily in a relaxing environment and a comfortable position at about the same time each day, and to report a trend toward decreasing motion. Actually, this is a good practice for all pregnant women, as it increases the awareness about the activity status of the baby, assuring general fetal well-being. If diet alone does not achieve the fasting blood glucose goal, insulin therapy might be prescribed. Oral hypoglycemics are never used in pregnancy because of the potential adverse effects on the fetus. Make sure you give the client detailed instructions on the method of insulin administration